The current evidence acknowledges that risk mitigation strategies against aerosol generation should be used for lung function testing in all settings and to protect all people, whether they be healthcare workers, patients, carers, administrative staff or cleaners. Factors that contribute to the risk of transmission of the virus that causes COVID-19 include activities with forced exhalations, such as lung function tests, but also loud speaking, cough, sneeze and exercise. Other factors that increase transmission risk include viral load that occurs with acute symptoms, the distance from an index case and duration of exposure, and environmental ventilation. Where there is a high prevalence of COVID-19 infection or local logistic or workforce limitations, GPs should only consider spirometry testing of their patients when it is necessary for clinical decision making. Patients should be screened for infection risk prior to spirometry testing. Contacting patients via telephone or email in the day or two prior to the clinic visit may be useful in identifying new symptoms or recent COVID-19 infection or exposure as a close contact and provide an opportunity to reschedule the appointment. This questioning should be repeated at the time of the appointment to assist with collecting recent symptom and exposure information. Prior to spirometry, the following COVID-19 patient screening questions can be asked. In the last 72 hours, have you had any new respiratory symptoms, such as fever, chills, runny nose, sore throat, cough, shortness of breath, or loss of taste or smell? All symptomatic people should be referred for a COVID-19 test. Have you arrived from overseas in the last 14 days? Have you been in contact in the last 14 days with anyone that is suspected or has been confirmed as a COVID-19 case? Are you waiting on the results of a COVID-19 test? Have you been directed to quarantine or isolate for any reason in the past 14 days? Are you immunocompromised? Practices could consider implementing a formal questionnaire and consent process. While PCR testing remains the gold standard for the diagnosis of COVID-19, the rapid antigen test has been accepted as one of several tools that can be used in conjunction with other risk mitigation strategies. Practices could consider targeted testing of patients using a rapid antigen test and defer lung function testing if positive. It is important to be aware that a negative rapid antigen test does not exclude disease and therefore should not be used to inform the use of personal protective equipment whilst performing lung function testing. The January 2022 Australian COVID-19 Test and Isolate National Protocols suggest that patients who have had recent COVID-19 infection should avoid high-risk settings for at least another 7 days after release from isolation, and close contacts should avoid high-risk settings for at least 14 days after exposure to the person with COVID-19. Taking a precautionary approach, this means that spirometry should be deferred by a minimum of 7 days after release from isolation or quarantine. In most cases, this will correspond to a minimum of 14 to 28 days after the onset of COVID-19 infection or exposure. Spirometry may need to be deferred for even longer times in immunocompromised patients due to ongoing virus shedding. In patients recently cleared from COVID-19 infection, consider scheduling them to separate them from other potentially immunocompromised patients or at the end of clinic lists. Adequate ventilation in patient care areas plays a key role to help prevent and reduce infections and provide safe working environments for healthcare workers and patients. 12 air changes per hour or 160 litres per second per patient are recommended for rooms where aerosol generating procedures such as spirometry are being performed. The air changes per hour metric determines how quickly airborne pathogens are removed from a room. For example, if your ventilation system is 2 air changes per hour, it will take 138 minutes to remove 99% of the airborne contaminants, and this drops to 23 minutes with 12 air changes per hour. Optimal relative humidity is around 50% to reduce transmission of airborne infectious organisms. Air conditioning units such as split systems or heat pumps will only heat or cool the supplied air, however will not improve the overall ventilation of the room. If your ventilation system falls short of the ideal standard, then there are a number of strategies recommended by World Health Organization that can be used to reduce risk of spread of COVID-19. These include increasing the percentage of outdoor air supply to the air conditioning unit, upgrading filters on air return ducts, maximising ventilation by using natural ventilation through opening windows, using a correctly positioned standalone air cleaner with HEPA filter to cover the gap between the minimum requirement and the measured ventilation rate, using window or wall extractors or whirlybirds, reducing the number of people in a room and leaving rooms unoccupied between testing. Ventilation is a complex area and expert advice may need to be obtained. Spirometry should be performed in single rooms, not shared spaces. Where practical, social distancing should be maintained with minimal waiting time inside the practice. Practices could consider encouraging patients to wait in their cars or outside, preferably under cover and weather permitting, to be called for testing at the appropriate time. Where practical, only the patient undergoing testing should be in the testing room. Exceptions may include parents and guardians of children and essential carers of vulnerable patients. Accompanying persons should be screened for infection risk as previously outlined and should wear a surgical mask in the testing area. It's recommended that all patients attending for spirometry testing should wear a surgical mask in the testing area other than when they are performing spirometry manoeuvres. Whenever possible, maintain social distancing of 1.5 metres between the patient and the healthcare worker in the testing area. Signage and line marking may assist in reminding patients to adhere to this. All staff conducting spirometry testing should have up-to-date vaccination status as per the appropriate current public health directives for healthcare workers. All healthcare workers conducting spirometry testing should wear, as a minimum, N95 respirators and eye protection, either face shields or goggles. N95 respirators should be fit tested and individual fit checking should be carried out before use. N95 respirators should be secured by head straps. It is only surgical masks that are worn using ear loops. Inline filters significantly reduced aerosols, and while they do not eliminate aerosols completely, it is essential that all spirometry testing is undertaken with inline antiviral filters in place. Inline antiviral filters are attached to or incorporated into the spirometer single-use disposable mouthpiece. It is recommended that you contact your spirometer distributor or representative to inquire about the availability of the correct inline filter for the spirometer you are using. Testing should not proceed if an inline filter is unavailable for your spirometer device. It is recommended that patients always follow standard cough etiquette and respiratory hygiene practices. Patients should be instructed to face away from the healthcare worker and, where possible, cough into their elbow or their mask or a tissue. Any tissues used should be disposed into the nearest waste bin after use, and the patient should apply hand sanitizer directly afterwards, as per the 5 moments of hand hygiene. Patient contact time should be minimised to decrease risk of infection transmission. A minimum of 3 acceptable and repeatable manoeuvres is desirable to meet ATS/ERS test quality criteria to achieve good quality interpretable spirometry. Consider not continuing with testing if the patient is having difficulty with completing acceptable manoeuvres. A description of test quality against ATS-ERS criteria should always be made available to the interpreter of the spirometry test results. Where possible, request the patient to bring their own short-acting bronchodilator inhaler and spacer for use during testing. Alternatively, the practice will need to supply a single-use spacer and metered dose inhaler where bronchodilator response testing is required. Standard infection prevention and control practices such as hand hygiene and cleaning are essential. In between patients, clean and disinfect all surfaces in contact with the patient, including scales, stadiometer, desk and chairs, and testing equipment. Use wipes or disposable cloths impregnated with a suitable disinfectant and leave to air dry.